All right, good evening everyone, and thank you so much for joining me this evening. I bring you greetings from Winnipeg, Canada, and just absolutely delighted that you've decided to spend an hour with me this evening. Pretty darn excited about this latest advancement in accelerated orthodontics, and I want to share with you some cool things that we've been discovering about it and how our patients have been reacting to it and how it's starting to make a bit of a paradigm shift in our practices as well. So it's going to be a fun hour, and thanks again for being with me this evening. I am wet-fingered orthodontist from Winnipeg, Canada, and tonight we're going to, it's pretty well the introduction to micro-osteoperforation that I'm going to share with you. I'm preparing another one which will be a little more advanced once you have been able to try a few cases and get into this and probably have some new questions. So I'm working on a brand new presentation for that day, so I hope you'll join me then as well. I do not have any financial interest in this besides Propel giving me an honorarium for tonight's presentation. But I've worked also with, of course, Invisalign and Henry Schein Orthodontics as well. But otherwise, I'm an independent orthodontist. I have a large practice in Winnipeg, Canada, and I just get a kick out of new technology and teaching orthodontics. So this statement is really becoming more and more accurate every day, and I honestly believe that orthodontic acceleration is going to be the gold standard for orthodontics going forward, and those of us who are early adopters have already seen some of the neat benefits of orthodontic acceleration. And I think up until fairly recently, we as orthodontists have concentrated a lot on mechanics, as in nickel titanium wires, heat activated wires, friction-free environments, and all of these things to kind of speed things up, light, gentle, yet constant forces. But now there's been a bit of a shift to attention to the bones and bone biology, and how that, focusing on that, can actually change the rate of tooth movement. And it's not a new idea, actually, and we owe a debt of gratitude especially to Wilco, the brothers Wilco and their team, who discovered that causing inflammation can actually speed up tooth movement. There were studies before them as well, but they kind of were the ones who kind of put it into practice. But their technique, of course, is really quite invasive, and we've discovered that we have to be a little bit invasive, but not quite that invasive, to have some good success with accelerating orthodontics, and that's what the story is about this evening. So where the big effect is inside of the bone. We actually cause an injury. So we're going in through the alveolar mucosa and into the periosteum and through the through the cortical bone and into the cancellous bone. And what we're doing is recruiting cytokines. And cytokines are the messengers that actually get to the actual cells that change bones. And of course they are osteoclasts and osteoblasts. And increase cytokine activity and you'll increase the rate of bone remodeling and decrease bone density, temporarily of course, and that makes for faster tooth movement. We've been at this a while, and we understand that that the rate of bone remodeling is very much related to the speed of tooth movement and the patient's treatment time. And I think it's kind of the holy grail right now as far as making patients happy, and especially adult patients. It's like, okay, yes, you're going to get me a great smile and a fantastic bite, but how long is it going to be? And one of my colleagues has such a neat idea, and that is he actually doesn't introduce the concept of orthodontic acceleration to his patient until the first adjustment appointment. And especially with braces, he's told me that the patient kind of comes in and goes, okay, like, you know, I'm stuck with these things, but is there any way that we can speed this up? And sure enough, the answer is yes. And he's had a pretty good closure rate on recommending micro-osteoperforation to that group of patients. And we've really kind of refined this now into a simple and easy in-office procedure that is now fast and safe and relatively comfortable as well, which has been a bit of a pleasant surprise. And I have a new delivery system to introduce to you this evening as well. It's kind of the third generation of the Micro-Osteoperforation Devices introduced by Propel Orthodontics. Dense bone will temporarily be softened with this and undetectable to the patient, but these movements with the cytokines and then the cellular activity increasing will make the movements happen faster and easier. And when I say easier, I mean especially with systems like clear aligners, we're finding that they not only are the teeth moving faster, but they're tracking so much better, and the teeth are staying with the aligners so much better, and there's less space like between the aligners and the teeth, and especially around the attachments. So that's pretty exciting because there's nothing more frustrating when we're using clear aligner therapy to have teeth left behind as the aligners go on, especially of course upper lateral incisors. And the magic number seems to be about 2.3 times the rate that would have happened without micro-osteoperforation. A lot of this science we've kind of discovered backwards, and we understand that taking out cytokines or getting in the way of cellular activity actually slows down tooth movement significantly. And a good example of this is our older patients who are on osteoporosis treatment. They'll be taking bisphosphonate medications, which actually have their mode of action to get in the way of this process. And sure enough, it really slows down tooth movement. So the opposite speeds up tooth movement. And that's kind of neat. So if we take out the cytokines, in animal studies, we've significantly decreased the rate of tooth movement. And the corollary, of course, is quite true. So therefore, we know these cytokines are the magic that will help us be the rate limiting or rate enhancing step when it comes to moving teeth. Pretty exciting stuff. And of course, we really know that bone remodeling is where it's at, and that the cytokines are the important recruiters of our bone remodelers, and in particular osteoclasts and osteoblasts. So we're all very familiar with these sorts of diagrams, how we actually put a little bit of force on the crown of a tooth, and it translates to the root of the tooth, and we get some vascular constriction on the pressure side, and that causes some fiber production, and this is what gets the cellular activity going. And we know, especially in an adult, that we really have to cause an event to make all of this happen. Of course, in a child, these cells are already quite active because they're growing. But in an adult, we actually have to cause this disturbance. And that's why micro-osteoperforation is so neat, because it temporarily causes an injury which causes some inflammation and recruits these cells to increase cellular activity. And then, of course, on the tension side, we're getting some new excuse me, osteocytes that are being formed. Osteoblasts and are active on the tension side, and so the bone fills in behind the tooth. So there's resorption on the pressure side and deposition on the tension side, and we're all very familiar with how that moves teeth. And we've also become quite familiar lately with how effective it is to be very gentle yet constant with our force levels. And we also have come to learn that too much force can actually cause what's called undermining resorption or hyalinization, in which we totally take out the blood vessels on the pressure side. And so it's a bit counterintuitive that more force won't move teeth faster. In fact, it really gets in the way of moving teeth. And I've often had patients say to me, hey, doc, I don't care. Like, if you go ahead, hit me hard with these forces and let's get this done. But that's actually the wrong way to go about it. And I like to use the analogy of golf, where a nice, easy swing with a titanium club, follow through and let the club do the work, and the ball is just going to sail. So I've figured that out in tooth moving, but not necessarily in golf just yet, but trying. And of course, the other players are our macrophages that are kind of the cleanup cells, and of course, we want to keep those blood vessels alive and well. And another real contributor to this science, I think, has been Dwight Damon, and he really helped us to understand that that light, gentle, constant force is the key to efficient tooth movement. And of course, we're seeing less pain when it comes to that. We're seeing less root resorption, and I think it's been a real neat evolution in orthodontics. And the concept of micro-osteoperforation really dovetails nicely into that. So a lot of this work was done at New York University, and they took the original concepts of causing inflammation and therefore moving teeth more efficiently and faster, and put it into a neat little package called the Propel device. And of course, this has been published in our referee journal, in the American Journal of Orthodontics and Dental-Facial Orthopedics in November of 2013. And Dr. Alicani and his colleagues did a really nice job of setting up a split mouth study where on one side they moved some canines into an extraction space without micro-osteoperforation, and on the other side of the same mouth they used micro-osteoperforation to move the teeth into that place. And they measured things like how far the tooth moved and how fast the tooth moved, and also the inflammatory markers in the gingival crevicular fluid at 28 days. And they were able to show a 2.3-fold increase in the velocity of tooth movement. And that's pretty compelling, actually, if we can tell our patients that, hey, by the way, we're going to do this about twice as fast. That's pretty neat, and I think it's the next level of great service for our patients. And we're going to keep with the tenet of first doing no harm as well. So they created the bone perforations. We were able to reduce the treatment time, and canine retraction happened at a 2.3-fold increase in velocity. There's some nice bodily movement, and we'll talk a bit about the placement of these micro-osteoperforations in the interest of getting the best positioning and the best effect in the bone and where we want it to be. And very little post-treatment discomfort. We'll talk a bit about that, but in general, I've been having good reports that when the anesthetic wears off, the patient doesn't really report much in the way of post-treatment discomfort or pain or bleeding. So here was the setup, and on the right side they retracted these canines off of a TAD without micro-osteoperforation, and on the left side you can see that the same setup was used, except that they also incorporated micro-osteoperforation. And after 28 days you can see there's quite a difference in the amount of tooth movement that occurred on the MOP side versus the non-MOP side. So the right side was just kind of getting going, and the left side was well underway. And we've really seen that in my practice, and I'll show you a few of my cases where that has occurred. As I mentioned, that this idea is not totally new, but kind of recently neatly and safely packaged for us. There's been a few other ideas out there, and some of them are still out there. Things like light-activated bone regeneration, and of course vibration technology, which is perhaps the sort of second most interesting one to me, and that is using these micropulses to increase blood flow and cellular activity. The issues I've been having with that system have been that we really do rely on patient cooperation. There's an actual little recorder inside the device that you can put into your computer and figure out whether or not the patient is wearing it. And almost without exception, I've been finding that my patients haven't been the best compliers with it. Even though it's only 20 minutes a day, they do seem to have trouble finding that amount of time. And right now, as well, the devices are really quite expensive. And in Canada especially, our dollar, along with the price of oil, has gone into quite a downward spiral. So it's become more of an issue for us in our practice. I mentioned to you Orthodontics, and that is the corticotomy procedure where they're actually doing sort of ear-to-ear flaps and scoring the bone. A lot of the procedures they're also doing simultaneous bone grafting. It's really quite the procedure, and it's a high cost to the patient and a lot of recovery time and fairly dramatic and invasive. And it also requires, of course, usually either a periodontist or neurosurgeon to help us out, and that pretty well doubles, or in certain cases can 3 times the cost of the orthodontic treatment. Piezo surgery as well, also requiring more invasive procedures, and but it's slightly less invasive, but still there is a flap, and there's a lot of learning curve that goes with it. And then along came micro-osteoperforation, and I'm just really excited that they've taken a lot of the same concepts of slightly invasive injury to the bone causing increased cytokine activity, but in a much less invasive package, and kind of easy to learn and not too tough for the practitioner to take on. So here's sort of the 3 generations of the micro-osteoperforation device, and the third one really is quite new. The original one had a cute little LED indicator light. We preset the depth to which we wanted our little self-tapping threaded device to go into the bone, and then it would light up when we got to that level. The second generation, a little more environmentally friendly in that we were able to only single use the tip. The handle is actually removable and autoclavable, and there's 2 versions of this one with a little sleeve, as you see here, and one without. I actually like the one with the sleeve because it gives me a little target, and also these sleeves have graduations on them to let you know how deep into the bone you are, or into the through the gum and into the bone, sort of 2, 4, and 6 millimeter graduates. The latest is this contra angle, and it is an electric motor, and it's very well governed and well protected so that we don't go too fast. A real enemy of this procedure would be heat, and so a lot of people say, geez, you know, that looks a lot like my slow speed handpiece, why don't I just use that? But this device is actually very controlled, and the fastest it will go is 45 rotations per minute, which is pretty slow even for a slow speed. And so we really don't want to go much faster than that, because there's danger of necrosing the bone as opposed to just causing it a bit of inflammation. So really caution you against using substitute devices, and instead stick with the micro-osteoperforation devices that are built precisely for that purpose. Patient benefits, you know, really not much downtime afterwards. We find that it's very well tolerated by the patient. And of course, in my practice, almost everything now is non-compliant. We sure do our darndest with things like class 2 correctors that are fixed and expanders that are not removable, and all those sorts of things. And so this is neat in that it keeps with my philosophy of not really asking the patient to do much beyond showing up and brushing their teeth and maybe wearing some rubber bands. So some of the other devices, as you've seen, really do require a high level of patient compliance for their success. Practice benefits, I kind of like the idea of being on the cutting edge of technology. There is indeed increased case acceptance if the patient knows that they're going to be in braces or aligners a shorter amount of time. That's going to be cool to them. It attracts new patients. They're looking for faster treatment time. Everything these days, it seems, is instant, and the faster the better. We reduce our patient burnout as well. I know a lot of you are thinking, boy, you know, what am I going to do about my fee schedule if I'm cutting my time in half that I'm going to be in braces or aligners? And I promise to share with you some thoughts about that as we get to the end of the webinar today. So here we go. First of all, we want to kind of evaluate the treatment area, palpate the tissue. We want to look at our x-rays, and we actually want to be between the roots of teeth, but I can tell you from experience that you'll know if you're getting too close to the root of a tooth. And we also know from some of our TAD investigations that you can actually literally run into a root with a screw or one of these devices, and as long as you don't keep going, you back off, there will be no untoward consequence. So just kind of watch where you're placing the micro-osteoperforations, and everyone will stay safe. We have our patients rinse 2 times for 1 minute each with chlorhexidine rinse before we start, and then away we go. There's a couple of ways to anesthetize. There is a pretty concentrated topical out there, and I'll encourage you to ask your Propel rep about the preparation. And a lot of, especially orthodontists, seem to like it because it doesn't involve a needle. I prefer actually myself personally to give a little infiltration. I like the idea of the patient not feeling a thing, and also I like the vasoconstrictor as well. However, I know a lot of my colleagues do like the topical anesthetic and are doing a great job with it. And the other thing is we've learned is you really don't have to go that deep into the bone. At first we thought, you know, hey, you know, the deeper the better. Let's get right in there through the cortical bone and well into the cancellous bone. But that actually isn't necessary. And we find just getting about 2 millimeters into the cancellous bone and we get the desired effect. Most patients require about 1 to 2 treatments. Up to 3 in certain complex cases. At first we were hitting them like every time we saw them, and we found out that that actually does not make any more benefit, and in fact may cause a little bit more trouble. So the magic number seems to be 12 weeks of effect for the micro-osteoperforation. We like about 2 to 3 micro-osteoperforations on the mesial and the distal, and sometimes not. By that I mean certain anchorage situations where we want the effect to only be in one direction. We can actually perforate only in that direction. And I think that's one of the advantages over some of the other techniques too that are rather full mouth and you can't really localize where you're getting your effect. So that's kind of a neat thing about the micro-osteoperforation. We can be strategic about where we place them when we're thinking about things like space closure and anchorage as well. We get a nice little halo of osteoclastic response of about 6 to 10 millimeters around the treatment site. This comes into play, say, you know, we want to get a central incisor going on the upper, but there's a big frenum in the way. We don't necessarily have to be on the mesial of that central incisor, because we know that if we hit the bone on the distal of that central incisor, our halo of effect is going to be well to the mesial of that root as well. So no worries if there's certain anatomical reasons why you can't get exactly where you want to be. Just know that the osteoclastic response has a pretty good circumference. We perforate around rate limiting movements, and in this for this I mean you know, canines that you struggle to bring down. Lower incisors I use it a lot in, and I know you'll know what I speak of when I talk about glass teeth in concrete. You know, a deep bite, the teeth are worn. Patients got exostoses, the teeth have been there for a long, long time. You can imagine just trying to move those teeth. It's the braces or aligners really, really struggle with that. So it's kind of neat to have this in our quiver to pull out and actually help. And I'll show you a case or two where that has really, really helped us along. Generally, in the anterior, we want to go in about 3 millimeters, so that gets us through the gingiva, through the periosteum, through the cortical bone, and into the cancellous bone. Posterior, because of the anatomy, generally 5 to 7, and on the palate, generally we want to go in about 7 millimeters. The effect peaks in about 1 day and remains elevated for about 10 to 12 weeks. So we've learned that recently with this system, where you don't necessarily have to do it every time you see the patient. And the magic number seems to be about 12 weeks, where if you still feel you need it, that's a good time to repeat it. And you can go ahead at that time and repeat it as necessary. Single-use device, as mentioned, we set the depth, and then the little light comes on once we've hit it. With the reusable handle and the little sheath that's around it, it has graduations on it that show us how deep we get in. And pardon me, they're at 3, 5, and 7. I think I said 2, 4, and 6, but what I meant was how far you are into the bone, usually through 1 millimeter of gum first, and then 3, 5, and 7 millimeters is the total. And it's a tighty-righty movement. Rotate counterclockwise. Rotate clockwise to get to the desired depth, and then counterclockwise, lefty-loosey to get it back out. So here we are. This is a little video. Thank you to my orthodontist associate, Dr. Inez Geddes, who actually allowed me to, first of all, to micro-osteoperforate her, and also to put it on videotape. So here we are. She actually had premolars removed as a kid and had orthodontics and had some spaces open up. So she put braces, we put braces on her, and she wanted to close the spaces quickly so that we could get this show on the road. So here she is. We're already in space closing wires, but she wanted to hurry it up. So first of all, gave her a bit of local infiltration, and as mentioned, I like to use an infiltration with a bit of vasoconstrictor in it. There it is, the removable handle, and you can see the graduations at 3, 5, and 7 millimeters. And the little sheath that goes around it. So the part that has to go into the sharps is this part here, and then down here this device is autoclavable and reusable. Each of these devices, just depending on how many you order, are just in around $100, you know, US, a little bit more if you don't order a whole bunch of them, but considerably less than a lot of the other systems. We really want to try and get about as 90 degrees to where you want to perforate as you can, and so that's why I'm really excited about the contra angle in the new electric device or rechargeable device, because we think it'll be a lot easier to get back into certain areas like this. You can see how much I've had to retract her lips to get into the right spot. So it's a clockwise turn, and you can actually get a feel for this. You'll feel the various levels that you're in. You'll feel it go through the gingiva, and then you'll feel it go hit the cortical bone, which is, as you know, is really quite hard, and then there'll be this sort of acceleration as you hit the cancellous bone, and we want to go about 2 millimeters into the cancellous bone. Back here, I generally go about 3. We want to be at least 2 millimeters apart, so don't, connect the dots. And it's okay to be in the alveolar mucosa, but we can put some also into the attached gingiva as well. And I'm doing them right in the middle of the space that I want to close, and on either side of the teeth that I want to close into that space. So sort of in this case, each side we were doing 9 perforations. And there's a bit of a push with this. Another reason why I'm excited to use the electric contra angle is I don't think there'll have to be as much pressure because the little screw will kind of do its own thing. Sometimes we get a little bit of hemorrhage, sometimes more than others, but generally it's a rather clean procedure, and you'll feel the catch, and then you can just back it out once you're sure you've been in there and got a good perforation. The wounds, after about 48 hours, you won't even see them, but we do know that the effect is there. It peaks at 24 hours and keeps going for 12 weeks. So that's what they look like immediately after they're done. Have the patient rinse with the Paradex or chlorhexidine rinse for the next 3 days, keep things nice and clean, and away we go. So either buccally or lingually, usually the buccal aspect is the most accessible, and but it depends, of course. Obviously, if we're doing things like impacted canines, we're in on the palate for sure. Recommended depth, as I mentioned, generally 3 towards the anterior, 5 in kind of the middle teeth, and sometimes 7 around mandibular molars and into the palate. This has changed a little bit. We actually found, especially amongst lower incisors, that we really don't need 3, and sometimes even 1 is enough. But generally, I'll err on the side of a few too many, and generally do 2 between lower incisors and 3 between upper incisor teeth. They don't necessarily have to be in a straight line. You can see that they can be in an L-shaped pattern as well. So we talk about 2 sort of ways of using these devices. One is proactive, where we've actually thought about it in advance and set it up accordingly for our patient. But I'm using it more and more in my practice as in a reactive way, as in I run into a tooth or some teeth that just aren't behaving, and I'm just so delighted to have this device in my back pocket that I can pull out and actually move things along. And we'll talk once again a bit about fees, but generally when it's reactive, I'm getting myself out of a bind and often won't charge for it because I'm aware of the economics of moving things along, and also the goodwill that comes with that as well. So we use it a lot with clear aligners, and it's really conducive to some nice tooth movement. We also use it with brackets as well, and of course it's kind of neat for space closure and helping out with difficult movements that either braces or aligners will struggle with. And I think of things like rotations and extrusions can really help things along. That's what the little wounds look like, and as mentioned, they're very temporary. They go away quickly, and our patients have reported really nice post-operative course with this. Interesting thing that comes out of this, we actually are intentional about producing inflammation, so we actually don't want our patients to use anything that is actually anti-inflammatory. So we really do stick to things like acetaminophen as opposed to ibuprofen, because of course ibuprofen has an anti-inflammatory effect. So we're careful to mention to our patients, if they do have some pain, let's stick to Tylenol as opposed to Advil or Aleve, and do a thorough medical history as well. And I think that people who are on things like bisphosphonates or other or certain anti-inflammatory medications, this may not be as effective because of its mode of activity. You know, we use them pretty well in all of our types of tooth movements, and basically we're not reinventing how we're moving teeth. We're actually just speeding up the various things that we do in orthodontics. This one's a neat one. I've been trying lately. I know it's maybe a little bit off-label, but I've had some teeth that we're just really trying to hurry up to bring them down. Maybe, you know, we get everything else but a second molar down, and so without sort of exposing them, I've actually micro-osteoperforated around where I know they are. And stay tuned. We'll see. I'm not sure if that's really going to help to hasten their emergence into the mouth, but it kind of made sense to me, so I've been giving it a go. All right, so let's look at some actual clinical cases. And of course, they really work well with Invisalign, either and ClearCorrect, whichever or whatever clear aligner system you happen to be using. And this is really compelling stuff where before we would have thought about, you know, let's see, we're going to use 32 aligners here. That's going to be 16 months. But all of a sudden we're down in the range of 10.5 months with 3 micro-osteoperforations. And we save 5 months, and that means usually about 4 times the patient has to sit in our chair. And that's neat, both savings to us and also goodwill for the patient to go from there to there in 10.5 months. That's a pretty neat practice builder, in my opinion. I think, you know, in general, we're probably a little bit more careful and long-term about our retention in these cases. We know that this amount of tooth movement, maybe some of the follow-up, the stuff that the osteoblasts are doing, will take maybe a little bit more time, but so we're just a little more careful. We're careful in general with adults anyway about retention, so it's not like it's a new thing to us. Here's one we're using. Of course, we're using aligners for class 2s here, and we get nice alignment within each jaw. And of course, we're using things like elastics and precision cuts to get some class 2 correction as well. There was a time when we thought all of this would take us about 24 months, including the class 2 correction. And my colleague, Dr. Shipley, has been using 3-day trays and having some great success with them tracking with micro-osteoperforation. So he's taking 24-month treatments and making them 6-month treatments. So that's pretty exciting. And I've talked to him about it. In general, I'm down to about 1 week Invisalign and aligner changes, but Dr. Shipley is down to 3 days, and he says patients really comply, and their aligners don't get very mucky in 3 days. So it's been interesting to me, and we're going to continue working with that. So 6 months from there to there, and that is quite compelling with only 1 micro-osteoperforation application. Class 3s, of course, we're using clear aligners these days, along with things like class 3 elastics in our precision cuts. This case was treated out in 5 months with 2 micro-osteoperforation applications, and no refinement as well. I think that's a key point too, in that, you know, so many times our ClinCheck says one thing and our final result says quite another. And the other neat thing about micro-osteoperforation is that our aligners track so much better. So it's not only faster, but it's more accurate as well. And although I'm not opposed to case refinements, and it's no sin in my office, it should be nice to avoid them if you don't have to scan the patient again and send them back for more aligners. So here we are, 5 months, 2 micro-osteoperforations, and we get from there to there. This case, ectopic lateral incisors, and course, we're using aligners for this as well these days with things like with our power ridges in order to get the third order of tooth movement and torque. And this case at one time would have thought to be about 18 to 20 months, and we were able to cut that down to about 10 months using 3 micro-osteoperforation applications. Once again, faster the better in the patient's mind in most cases. So we got from there to there in 10 months with 3 applications of the system. This one, we're underway with some crowding. This one a little more reactive, so we get sort of partway along, and the case really isn't responding all that well, so we bring out the micro-osteoperforation, and we get the treatment time down to 6 months from an estimate of sort of 15 months. So kind of neat that we're able to save that amount of time and go from there to there in 6 months, and that once again is quite compelling. Here's a situation where we've taken an upper central diastema and we're closing it with clear aligners. Generally, we would have expected with our 2-week intervals to have had this case treated out in about 38 weeks, and Dr. Shipley was able to accomplish this in 8 weeks with 1 micro-osteoperforation. You can see where he has applied this. There's a neat example of not necessarily wanting to do this right into such a large labial frenum, but we know that if we place these micro-osteoperforations on the distal of these central incisors, the effect is going to be well into the central area as well, because we know that we're getting 6 to 10 millimeters of halo. So go from there to there in 8 weeks. That's pretty neat, and a pretty good practice builder, I would say, for sure. Here's one, lower anterior crowding, and sometimes these are quite miserable to deal with Invisalign or clear aligners. 28 weeks and 14 aligners was the original, and in this case, the case was treated out in 8 weeks with 1 micro-osteoperforation. Patient also had a tongue perforation, so she's now talking 2.3 times faster as well. There to there in 8 weeks. That's pretty good stuff for sure. Okay, lower incisor extraction, and we talked about some bodily movement that we were seeing in the original study, and how we'd like the roots to move as much as the crowns move, and that's been a really neat observation, and that is, quite often we'll see a lot of tipping first as we're trying to close this space, but since the effect is occurring in bone well down the root and close to the center of rotation of the root of the tooth or the center of resistance, we're actually getting some nice bodily movement, and we're able to show that with some imaging as well, and that's kind of neat stuff too. We're able to get that in 5 months with the roots coming along for the ride, along with the crowns of the teeth. 1 micro-osteoperforation application, 5 months, clear aligners, and you got to know that that's patients pretty happy at this moment. This one, deep bite. Of course, we're using the Invisalign users are using that G5 where we place the ramps on the lingual, the upper incisors, and the lower incisors hit them and help us to level deep curves of spee. And along with that, we can enhance that with micro-osteoperforation as well. This one, 3 months, and 1 micro-osteoperforation, and the change of the aligners is about every 7 days. Of course, we also use micro-osteoperforation along with braces. This is one of my cases. We got underway. This is that situation where I described, deep bite and worn teeth, and you just got to know those lower incisors are going to be miserable. So we get our nite wire in there, and I decided to micro-osteoperforate. You can see where I've placed the micro-osteoperforations. This one I actually did in my own little study, in-mouth study, because I didn't perforate around the premolars and the molars. I sure would today, but you can see how little they moved and how much the lower incisors moved. So it's kind of a neat little lesson for me to, hey, keep going around and try and hit all the teeth that that you want to move. So we got from there to there in 2 months, and that's pretty exciting when those teeth have been there for that long in that patient's life. And of course, nowadays I would keep going all the way around to the molars and just make it happen. This situation, I was struggling with all of my tricks, power chains and weaves under the wire and all sorts of things to get a lower incisor extraction space closed. I thought it would take me a good 6 months, and probably, as you can see, I was getting mostly tipping into the space here. And so I went ahead and did the micro-osteoperforation on either side of the teeth that I wanted to move into the space. And 3 months later, space is pretty well closed, and we're just snugging it up now and maybe bringing this root a little bit more mesially. But that was another one of an eye-opener for me, and has kind of allowed me to be able to be truthful about honestly believing that this system is very effective. So 3 months and 1 micro-osteoperforation, and we're there. This patient had lingual orthodontics on the upper. That's why you don't see the braces on top. This situation we see quite often. Missing premolars are quite often. This situation is congenitally missing premolars, and the baby teeth fall out. You got to close the space. And our colleague, Dr. Lipkin, managed to close this space using 3 micro-osteoperforations in 7 months, and that's a big space. So quite compelling once again to be able to do that. In a lot of these cases, we're using temporary anchorage devices as well to help with our anchorage in these cases. And I'll show you a case where we use micro-osteoperforation along with TADs, and they actually have a bit of a synergistic effect as well. 7 months, 3 micro-osteoperforations, and kind of neat. Another case that's kind of miserable in an adult where crowded out lower second premolars. They've been there forever. They're in the tongue space, and trying to get those to upright and open, like first of all opening the space and then getting those teeth to come buccally is sometimes quite the chore. But we're sure lucky to have micro-osteoperforation to help us out with this and basically cut the amount of time that it would take in half. So we got from there to there in 9 months, and that too is pretty compelling stuff. You can see the retention regimen here. Quite often we'll use these bonded retainers, lower 3 to 3, and then also have an overlaid clear retainer or a holly retainer to manage the back teeth as well. So you got to know those second premolars are going to want to move back a bit. Canine extrusion. This one was Dr. Pobance's case. A lot of people sort of took him to task because they said, "Hey, man, the second slide shows different braces," but this was a case where he actually took over the orthodontics and then changed the patient's brackets to clear ones. This situation, once again, impacted canines are really time-consuming and tough, especially the palatal ones that are so far in towards the center of the palate. So really a great spot to use micro-osteoperforation to help us along. 6 months and some micro-osteoperforation. He was using a lot at this point. Once again, we found that the magic number seems to be about 12 weeks to hit them. He was doing it pretty well every month, but really found out along the way that that is actually not necessary. Molar uprighting, of course, another difficult situation. We expect this to take at least 6 months, but we're able to cut that amount of time in half. The other thing we're doing in this situation is we're using temporary anchorage devices on top to intrude the opposing molar that is usually over-erupted with the missing and collapsed molars. And that too, we've been finding micro-osteoperforation is helpful for the intrusion of individual teeth. But the actual amount of uprighting that had occurred in 3 months with one micro-osteoperforation application is kind of neat. This is a nice illustration of what you can do actually in a month with some well-selected thermally activated wires. And we see how quickly those laterals come down. In this case, I think I probably would have done a bit of it on the lower as well to hurry along these incisor teeth as well. I think she might have actually down here. It's Dr. Kathleen George's case. 1 month. Kind of neat to see those laterals come down. You can imagine it's a real neat confidence builder for your patient too. That's pretty exciting stuff. A situation where we've got a fairly large space closure. You can imagine the same cells that are actually healing this socket are helping us out in this case. You got to know that there is a micro-osteoperforation effect to things like an extraction and the placement of a temporary anchorage device. But this can be targeted, as I mentioned, in the right direction so that we get the kind of tooth movement we want. So say we want this molar to come forward all the way, we won't necessarily perforate mesial to these teeth because we want them to kind of stay put. But instead we'll micro-osteoperforate on either side of this molar and into the edentulous space, and then we get that nice forward movement. In these cases, quite often I'll put a little TAD down here and tug off the TAD as opposed to the teeth for space closing. For 4 months, we get that amount of space closure that gets my attention for sure. In this case, we're actually replacing missing lateral incisors with canine teeth and reshaping them. And this one, 6 months. Dr. Pobance's case, once again, 6 micro-osteoperforations. Once again, we know now that that's actually a bit much, but did a nice job with accelerating the space closure. So got from there to there in 6 months. This case, anterior open bite, once again a tough situation to deal with, and if we can get from there to there in 13 months with micro-osteoperforation, we're going to be happy. We also talk a lot about tongues with these patients, and tongue posture, tongue up, not forward, especially when they're swallowing. Think of the N sound. 13 months, 3 micro-osteoperforation applications, and down we go. I mentioned we use it a lot with TADs. Quite often, you know, when I think TAD, I'm also thinking Propel because I'm using a bit of anesthetic anyway. One interesting thing is that I find I have to use a more robust TAD because the same effect that the micro-osteoperforation has on the bone surrounding the teeth I want to move, it sometimes has on the bone surrounding the TAD. So finding myself choosing a slightly larger TAD and maybe a little longer one so that it can withstand that sort of thing. But this case, this lady is going to lose a little cantilever bridge here, and she said, you know, I only want a space in behind the premolar and in front of the molar, and so you got to move all this stuff forward. And so I go, okay, here we go. So what happens is we do this once again off of a TAD, and it's at the same time while she's frozen up there, I will also use micro-osteoperforation. And you can see I've got a little pontic here which is getting smaller and smaller as we bring this tooth forward. I'm using a combination of coil spring and tugging off the TAD with a little jig that I've made out of a ligature wire and an elastomeric. And so at 3 months, I've already got this amount of space closure, space opening back here, this amount of space closure, and also the pontic's getting smaller and smaller. So it won't be too long, and we'll actually have this tooth touching the canine, and she'll be happy because she'll only have one edentulous space mesial to the molar. Here's another one where I've used TADs. Once again, I seem to get a lot of patients who want me to close a lot of space these days to save them an implant or a bridge. So we're excited to have Micro-Osteoperforation to help us along with this. We wanted pretty well mesial migration of this molar. This patient has lingual braces, you can see, and we also double cable this a lot, where we close from the inside off the lingual braces, and then we put a little button up to a TAD on the labial side, and that's what closes these things forward. And of course we're using micro-osteoperforation into the edentulous space, and away we go. At 2 months we've got that amount of space closure. So that too gets my attention, and kind of neat that we're not taxing the anchorage and putting her into underbite. So just to close out this evening, sorry, before we ask for some questions, I want to address a question that often comes up when I do live seminars, and that's, geez, doc, usually my fees are around, 18 months or so for these patients. Now you're telling me I'm going to finish them in 9 to 12 months. Boy, what am I going to do? Well, first thing is when we proactively anticipate using the Micro-Osteoperforation device, consider premium. I've heard in the range of $400 to $500 generally, depending on how many you anticipate and how much trouble this patient's going to give you. Reactive, as I mentioned, I'll often not charge for these, and the idea there is, hey, I'm speeding things up, I'm going to get myself out of a bit of a bind, I'm going to have less time with this patient and less chair time, and I find that that's enough of a saving to certainly pay for 1 or 2 tips, because we understand that economics and and also the benefit as being known as the accelerator, and in Winnipeg I am the accelerator, hoping to get a little cape and a mask pretty soon. I've got a hat now with a propeller on top of it too. There is a guide, a fee code in the guide, and I'll ask you to ask your rep. It's maybe a little bit different from state to state and province to province. So it is for some guides call it alveolar recontouring or alveoloplasty, and quite often you can charge it per sextant. And the recommendation is, take some photos and make sure that they're aware that you've actually gone into the bone, and then the insurance companies will often cover this. Shorter treatment time presents an interesting dilemma, as I mentioned. Sure, we've always sort of spread our fees out over 1.5 to 2 years, and now all of a sudden we're in the 9 months to 12 months, even for some pretty complicated cases. And so docs have been saying to me, hey, what do you do about this? One neat idea is to really try and take the money out of the medicine, and that is consider offering generous incentives for payment in advance, and then the patient kind of loses that connection between number of visits and number of procedures and number of adjustments and how much they're paying. So we'll offer a decent incentive for payment in advance, and no matter how many times you try and explain it, the patient always seems to have this payment per visit mindset, and if they don't come in a particular month, but we hit their credit card anyway, they get all crazy. So kind of neat if you can get it paid in advance, and then that eliminates that dilemma. The other thing that I've heard, which I thought was a neat idea, was define retention as part of the treatment as well. They call it the stabilization period. And I thought that was kind of neat too, that even though we're finishing earlier, hey, we're probably spending a little bit more time and effort on stabilizing these cases, and that's actually part of their treatment too. So a few more months of monthly payments during the stabilization phase, as long as it's well presented, is okay. Ladies and gentlemen, it has been such a pleasure to be a part of your evening. Thank you very, very much. What about potential root resorption? Is from Vasant Ramlagan. Due to faster movement? And the answer is we're not seeing it, and the reason is we are literally softening the bone, as in, although teeth are moving faster, they're not met with such resistance in the bone, and therefore with micro-osteoperforation we're not seeing a whole lot of of root resorption. Can you use this with expansion devices? Excellent. Another great question. And the answer is yes. And what we're doing is actually, say we're using like a Haas or some sort of screw type expansion device, will actually micro-osteoperforate on the buccal side. Most of these treatments are in adults, of course, and so we're a little bit careful about the rate, but we do find that the micro-osteoperforation helps with the alveolar remodeling that we need to get this expansion in adults. But once again, we're a little bit careful about it. And in a kid, not as necessary because, of course, in most of these kids, we're actually doing it in a rapid way and actually splitting their palates. Okay, thank you. You're welcome, Dr. Prabhu. It's good to see your name. Thank you. Do you think there is more risk to hit a root with the electric device? Excellent one. Dr. LeMay, we just started out with the electric device. It too, though, gives us pretty good tactile sensitivity, as in you can actually feel the layers. We're not, making incisions or anything like that, but you can feel as you go through the mucosa. When you hit the cortical bone, of course, you'll feel more resistance. When you're through the cortical bone, all of a sudden the cancellous bone feels like you're just in a sponge. And then, sure enough, if you actually get close to a root, first of all, if you're using topical anesthetic, the patient, if you get close to their periodontal ligament, they will jump. And so that's one advantage to actually using topical, because you'll know if you're getting close to the root. But you'll also have good tactile sensitivity even with the electric device. And so I don't see that as an issue. An absolute worst case scenario, you do get pretty close to a root. We've already been able to show with the research that we're not causing any trouble. Okay, Biomax extraction case, can you perforate on the facial and the palatal, or does the halo from the facial extend palatally? Another great, well-visualized question, Dr. Pop, and the answer is that halo is 3 dimensions. So especially with the handheld devices, they're a little difficult to get in and get a good sort of 90 degrees on the palate. I'm looking forward to better access with the contra-ankle device, but we do know that not only mesiodistally are we getting that halo, but also buccolingually. So I think the answer is you don't really necessarily have to go in from the facial and palatal. I think if you could easily and you can visualize it and stay out of trouble, I probably would. But otherwise it doesn't seem to be all that necessary. Do you use a new device every time you microperforate a patient, and can you reuse on the same patient? And the answer to both of those are a new tip on every patient. So the original Generation 1 device is a single-use device, and it is to be disposed as a sharp and a biohazard. The second generation with the handle, you can remove the tip and it's got to go away, and then the actual handle can be autoclaved and reused. And with, of course, the handpiece, you can also autoclave it, but the little screws are not reusable. Can an implant motor be used for the perforations? Okay, so I actually caution you for using devices that are designed for other uses for micro-osteoperforation, and you got to know that this has to be delivered in a rather controlled manner. And that's why, of course, with the handheld device, we can only go so fast with our hands, and that's why we stay out of trouble with it. But now we're starting to get into the motorized devices, but the actual, even the fastest that this electric rechargeable motor will go is 45 RPM, and so I think you may be asking for trouble if you exceed that and start using devices that are for other applications. So not recommended, but it's no secret that other procedures are causing the same sort of cellular effect, and I mentioned TADs and extractions, and probably the placement of starting an implant preparation will also do the same sort of cellular recruiting, but I caution you against having it happen too fast and too much heat. have you heard of this being used for perforation in bone regeneration surgeries, as in ridge or buccal augmentations? A fascinating question. Not much. So far, of course, we've been using it for orthodontic applications, but I know the great minds over there at Propel are always thinking of these things. And I honestly do think that this sort of cellular recruiting and enhancement has some applications well beyond orthodontics. So great question for the future, and stay tuned for sure. Dr. LeMay, do you use it at the first appointment? Another great question. If I'm planning on using it proactively, and especially in an adult, it is neat to use right off the bat, and the idea there is it's kind of like a jump start for the treatment. And but I mentioned my colleague that also introduces it at the second appointment, especially braces patients that are already disillusioned after 6 weeks with braces and they want to hurry things along. But yes, in general, it's used at the first appointment, and I'm excited about its effect. Before this, we used to have to wait for our orthodontic forces to get the system going and recruit the cells. And I feel like this is like putting a set of jumper cables onto the system to speed things along. Ladies and gentlemen, it's been a great evening. Thank you so much, and we'll encourage you to get out there and move some teeth much more fast and efficiently.